Hello and welcome. I'm Barbara McClean, critical care clinical nurse specialist and nurse practitioner and a hemodynamics expert. And I am so excited to have you join me today for understanding right is right, the role of right ventricular dysfunction in critical illness. As you know, I'm a paid consultant from the Edwards Life Sciences, but anything that I say here is in relationship to my clinical practice and my clinical expertise. So I appreciate you very much for coming to this program today, and I appreciate Edwards Life Sciences for their commitment to evolving the knowledge of bedside providers in the understanding of hemodynamics. So always when we start off with hemodynamics, there's a few rules that we have to review. First and foremost, understanding the difference between pressure, blood flow, and tissue oxygenation. And as we talk about pressure, to always remember that pressure measurement is a relationship of volume and chamber that is either compliant or non-compliant. And so we always remind ourselves when we're evaluating arterial pressure that we must consider two reflections, the compliance of the artery and the volume that finds itself in the artery. When we look at arterial pressure, we evaluate that in two different circulations. Systemic arterial pressure, very common. Most of us look at this every day in multiple ways. And then pulmonary arterial pressure, a little more difficult for us to evaluate and requires a pulmonary arterial catheter. Arterial pressure is always a reflection of volume and the compliance of the chamber being filled. And how lovely it is that that is also the role of venous pressure. Venous pressure is a reflection of the column of volume that fills a chamber, but in this case, the chamber being filled from the veins will be the atria, right and left, and the ventricle, right and left. So venous pressure reflects the filling of those chambers and most particularly is altered when there is a change in compliance rather than a change in volume. Then we look at blood flow. Blood flow is powered by cardiac ejection. It's not assured by cardiac ejection, but it's powered by cardiac ejection. And we consider two basic ways that we evaluate blood flow in the very best way we can at the bedside. And that would be left ventricular power and left ventricular ejection measured as stroke volume from a pulsatile waveform in an area under the curve measured by either the pulse or by the arterial waveform in an arterial line. And of course, stroke volume is affected by preload, afterload, and contractility. So primarily, volume, resistance, and the inherent property of the ventricle to contract against a volume to move it against resistance. Stroke volume is the amount of volume ejected per beat, and we measure stroke volume very effectively in our systemic arteries. Cardiac output, which is measured in the pulmonary artery utilizing a thermal dilution quality that actually tells us about temperature change over time, whether it's a cooling of the temperature or a warming of the temperature. Looking at that temperature change over time actually reflects the right ventricular power. Now, it's quite important to remember that if I'm using an arterial line or an arterial pulse, I'm actually measuring stroke volume, and stroke volume times heart rate will display as cardiac output. In the pulmonary artery, I'm actually measuring temperature change over time, which is an indirect reflection of cardiac output. And cardiac output divided by heart rate will yield stroke volume. So again, systemic arterial, we're measuring stroke volume and calculating cardiac output. And then, of course, the most beautiful component of hemodynamics, which is the left heart powers its volume that filled it against the resistance to ultimately deliver oxygen to the cells. So we use SaO2 to tell us about that oxygenated blood. We use the stroke volume to tell us about the LV power. And we look at our filling pressure to assure that we have adequate volume filling our ventricle. The purpose of the right heart is to return the relatively deoxygenated blood into the right ventricle so the right ventricle can power that blood flow up into the pulmonary vasculature where gas exchange will occur at the alveolar capillary interface. The goal of the right heart is to return that deoxygenated blood to the lung. And how deoxygenated that blood is before it returns to the right heart or after it returns to the right heart is measured as SCVO2, central venous deoxygenated blood, or SVO2, pulmonary artery deoxygenated blood. And the difference between the two is SCVO2 reflects the upper extremities and cerebral circulation, and SVO2 reflects all circulation that mixes in the right atrium, mixes in the right ventricle, and is ejected up into the pulmonary artery. So we're going to use these beautiful tools, pressure, blood flow, and tissue oxygenation and tissue deoxygenation, to truly reflect hemodynamically what's occurring for our patients. Basic Concepts goes on to remind us that when we're talking about our cycle, that our cycle of ventricular function is both filling and ejection. The filling phase is known as diastole, and the ejection phase or the contraction phase is known as systole. And we understand that we fill our right ventricle with deoxygenated blood from the systemic capillaries and veins, and we use central venous pressure and or right atrial pressure to reflect the filling of the ventricular chamber. And for the left ventricle, we're going to use very indirect surrogates because we're not measuring LA pressure and we're not able to measure pulmonary venous pressure. So we're going to look at the reflection of that filling pressure in the pulmonary vault utilizing either the pulmonary artery diastolic pressure or the pulmonary capillary wedge pressure. The purpose, remember, of the left ventricle is to fill with oxygenated blood from the pulmonary veins, the left atria, and the pulmonary capillaries. When we correlate that now to ventricular ejection, it becomes vitally important to remember the right ventricle is ejecting relatively deoxygenated CO2-rich blood up into the pulmonary artery to promote gas exchange, and what we typically measure is the temperature change over time that is reflected as right ventricular cardiac output. Now, we have other methods. We can measure our right ventricular ejection fraction. We have other methodologies to evaluate this function. But in general, what we're using today is cardiac output and the pulmonary systolic pressure. When we talk about the left ventricle, we have a lot more methodology that's simpler and that's more utilizable that we've been doing for years. We look at left ventricular ejection fraction. Now, the case I want to make here, because we're going to talk about this throughout the next sets of slides, is to remind ourselves that right and left heart are not the same, that they in general are synchronized, but they become dysynchronous, and therefore the cardiac output I measure from the PA catheter may not actually match the calculated cardiac output that I'm measuring in the systemic artery. So this brings us to one of the most significant assumptions that has been practiced in critical care since 1970. And that monitoring assumption is right heart is a reflection of the left heart. So in the original studies using PA catheters, when PA catheters were placed in relatively healthy medical students, right heart function reflected left heart function. In a healthy patient, that's true. But it's very important for us to remind ourselves that both ventricles must be functional and that both circulatory systems, pulmonary and systemic, must be without problems for that to be true. So we want to remind ourselves that acute changes in either RV function or LV function, acute changes in systemic circulation or pulmonary circulation, are going to disrupt this delicate intraventricular relationship. And to remind ourselves not to throw another baby out with the bathwater. So when we talk about central venous pressure as a reflection of right ventricular filling, it was never meant to reflect LV. It was always meant to reflect the RV. Our attitude was based on the assumption that RV end diastolic volume always correlated with LV end diastolic volume, and therefore we would use CVP to reflect the left ventricle. Now, in the recent years, we've discovered that not to be true. And part of this understanding is based on the realization that ventricular compliance changes in critically ill patients. The tension of the ventricle changes because of the afterload or the vasculature changes, and the compliance of the ventricle in and of itself changes related to myocardial injury, related to heart rate, related to positive pressure ventilation. And as we dissociate right and left heart, we will see an evolution of profound critical illness, and that requires us to have a good understanding and to seek the truth and the right answer. So, as we move forward, we'll uncover some of the major issues that impact right ventricular versus left ventricular function and dysfunction in critical care, and that will lead us to the understanding of right is right. So vitally important, as we've discussed, to understand the difference of right and left ventricular roles. That the left ventricle fills with reoxygenated blood from the pulmonary veins, and that the maintenance of a low pulmonary venous pressure maintains the appropriate mobilization of blood flow and limits extravasation of volume into the lung. We measure that as LA pressure, pulmonary capillary wedge or arterial occlusion pressure, and PAD. That the left ventricle ejects blood against a very high resistance, very significant arterial system known as the systemic vasculature, and that we measure that primarily as stroke volume in the systemic arteries. And we must remember that the contraction of the ventricle mobilizes the volume that fills it against a resistant compartment, and that when we are considering resistance, the calculated measure of systemic vascular resistance, we always correlate that back to work. We consider what that means in reflection to the work of the ventricle. If I have a high resistance, the ventricle must work harder. If I have a low resistance, the ventricle must work harder. Works hard to bolus blood against high resistance because the resistance is so high, and works harder to bolus blood against a low resistance because now the requirement is for the ventricle to fill the vasculature with volume. So these concepts are incredibly important. And remember, the role of the left heart is to mobilize oxygenated blood through the system to the terminal point, which is right heart filling. Now we correspond that to the right heart. The right heart is a conduit pump. It's what mobilizes the relatively deoxygenated CO2-rich blood up into the pulmonary vault. That right ventricle is profoundly distendable, and it fills with relatively deoxygenated CO2-rich blood from the central veins. And again, that right ventricle, which is very compliant, has a large intraventricular chamber, fills with that volume very simply and very easily. But as compliance changes, what will happen is you'll have an engorgement of your veins and a higher pressure that then exacerbates into congestion of the systemic tissues of what we would traditionally call peripheral edema. We look at right heart filling as CVP, the central venous pressure, the column of blood that fills the right ventricle and the exertion of pressure in the central veins. The right ventricle ejects that blood through the pulmonary vault, and that pulmonary vault is very low resistance, very short arteries and arterioles, and a really large capillary surface in order to promote the best possible gas exchange. Now, when we're looking at the ejection of blood from the right heart, we're going to measure that in the pulmonary artery as temperature change over time, also known as thermal dilution cardiac output. Whether it's with a heat pulse or a cool injection, it's thermal dilution, looking at temperature change over time. And we remind ourselves that that right ventricle has to contract, moving the filling volume against the pulmonary resistance. What that actually tells us about is that pulmonary perfusion pressure that is promoting the gas exchange at the lung. And our basic calculation here would be pulmonary vascular resistance, and that calculation tells us and is a reflection of how much work the right ventricle must do. The lower the pulmonary resistance, the better it is for the right ventricular pump, because in the healthy relationship, the right ventricle is a very low muscle mass with very low resistance and very low work. So as we expand our understanding of the right heart and its difference from the left ventricle, very important to remind ourselves, less myocardial mass, significantly less requirement for oxygenated blood than the left ventricle, which is the worker bee of the ventricular system. And to remind ourselves that because this is a compliant chamber, the right ventricle is very preload dependent. But it is also important to remember that that compliant ventricle has a low muscle mass and therefore becomes very sensitive to afterload changes. So if there's an increase in pulmonary resistance that's mediated by pulmonary hypertension, a pulmonary embolism, positive pressure mechanical ventilation, the load presentation of that right ventricle is a very difficult one for the right ventricle to overcome. In a compliant state, that right ventricle, it can accept huge amounts of volume challenge with very little failure of volume mobilization, with very little increase in central venous pressure, with very little extravasation of volume into the peripheral interstitium. The right ventricle is always affected by volume loss because volume is the main component of right ventricular filling. But in a high resistance state, when there's loss of compliance, the right ventricle will be profoundly affected. So vitally important in terms of understanding this function and the relationship is to appreciate the pulmonary circulation and the role of the right ventricle. To remind ourselves that the right ventricle historically and in our physiology and anatomy courses, we learn that the RV is basically a passive conduit between the systemic veins and the pulmonary artery. That the RV connected to that pulmonary circulation has a final destination. That final destination is ultimately the maximal filling of the left ventricle. And in order physiologically for that to happen, you must have a low pressure system in the pulmonary circulation. That PA diastolic pressure, which is resisting the RV ejection, should always be less than 15 millimeters of mercury. And when we apply positive pressure ventilation, or we have a pulmonary embolus, or we have vascular changes, and that PA diastolic pressure goes up, you are requesting the right ventricle to work harder and mobilize blood flow through a more resistant state, and the right ventricle is not prepared. So it's very important for us to appreciate that pulmonary perfusion and pulmonary perfusion pressures are absolutely required to improve gas exchange, to uptake oxygen into the blood, and to download CO2 into the alveoli. And that low resistance system must be maintained to prevent congestion of tissues or organs. Now, the pressure in that pulmonary system is very important because it reflects on RV ejection. And it also reflects on the LV filling. If the LV can't fill, the pulmonary resistance is going to go up, and the pulmonary pressures are going to go up, and eventually you'll have right ventricular dysfunction. But it's also important to remind ourselves that we can have primary RV dysfunction whenever the pulmonary resistance increases, because that alters the compliance of the right ventricle. We also consider the compliance of our pulmonary vessels with a large diameter and a thin wall, and any kinds of vascular changes that can occur will again offer a significant increase in resistance. And then, one of the most important issues is to remind ourselves that pulmonary vascular resistance is profoundly affected by hypoxia. When there is alveolar hypoxia, the normal pulmonary arterial response is to vasoconstrict and redirect blood flow towards alveoli that are more recruited and that have more oxygen. So as soon as we see alveolar hypoxia, what we can see is pulmonary arterial vasoconstriction, which then, of course, affects the right ventricle by increasing the afterload. And again, to always remember, the right ventricle, although preload dependent, volume, is afterload sensitive, and profoundly so. So now arises the pulmonary arterial catheter. The pulmonary arterial catheter is now and has always been, world without end, amen, a right heart catheter. When you get patients from the cardiac cath lab, the report will be, we did a right heart catheter. We did a left heart catheter, and we did a right heart catheter. The pulmonary arterial catheter was specifically designed to allow us to look at RV function and RV dysfunction. And in 1970, RV was assumed to be always reflective of the LV. But in the evolution of our understanding, the evolution of hemodynamic evaluation and understanding, and most particularly the evolution of our therapeutic interventions with vasoconstrictors, pulmonary vasodilators, and most importantly, positive pressure ventilation with alveolar recruitment strategies, we have put an extraordinary burden on the right heart. So when we see patients who have pulmonary arterial catheter, we have a unique opportunity to look at RV dysfunction. And most important for your clinical practice, because this reaches to every type of critical patient, the effects of mechanical ventilation, which can induce, indeed, obstructive shock, actually affecting profoundly RV outflow. Now, in conjunction with that, things that we always think about: patients with chronic lung disease, patients who have pulmonary embolus, patients who have known pulmonary hypertension. That will always put an extraordinary burden on the right heart. But frequently, chronic lung disease and pulmonary hypertension are issues that occur over time, and over time, the right ventricle may actually increase its muscle mass. Our number one concern in critical care is the unknown iatrogenic pulmonary hypertensive patient, and that patient deserves and requires a pulmonary arterial catheter to unfold the information that will guide our therapy. So again, the importance of the right side of the heart is to remind ourselves that the right side of the heart has an ultimate goal, and there really are two ultimate goals. Number one, to mobilize relatively deoxygenated CO2-rich blood into the pulmonary circulation for gas exchange, and ultimately to fill the left heart. And all types of interactions can profoundly cause dissociation here. Now, as we said before, the right ventricle is preload dependent. It is primarily, in a normal situation, a volume pump, not a work pump, not a pressure pump, not relying on an aggressive contraction. So in the normal state, hypovolemia and venodilation will profoundly affect right ventricular filling and therefore right ventricular ejection. In addition, the right ventricle is profoundly afterload sensitive. So again, we've talked about this before, to remind ourselves that in our critical care units, we often will know we have patients with chronic pulmonary hypertension, and we might float a PA catheter to evaluate that patient. But what I want us to remember and to understand, that the person with acute respiratory failure evolving to acute respiratory distress syndrome, to anyone that you are utilizing aggressive alveolar recruitment strategies, so that would include positive end expiratory pressure, PEEP, typically greater than 10, pressure control inverse ratio ventilation, or airway pressure release ventilation. All alveolar recruitment strategies put an extraordinary burden on the right ventricle. And remember, the right ventricle is profoundly afterload sensitive. So indications for the placement of a pulmonary arterial catheter are pretty straightforward if we open our eyes and expand our methodologies. So we will use that catheter to help us differentiate among different causes of shock and to look at the mechanisms of left ventricular failure to fill utilizing the indirect measure, pulmonary arterial occlusion pressure, or PAD. We'll look at acute and chronic pulmonary hypertension. And I want to further divide that because I want to remind you, you can have acute pulmonary hypertension with an acute pulmonary embolus, but you can also have idiopathic or what I call iatrogenic pulmonary hypertension based on your methodology of ventilatory support. It helps us, of course, in pericardial tamponade, helps us to look at left to right intracardiac shunts, and what also is so incredibly and profoundly important is the evaluation of right ventricular function with a primary RV infarction. So just as a reminder, we're going to consider primary RV infarction whenever we see inferior or infero-posterior MI. We're always going to consider the possibility of RV infarct. We might do a right-sided EKG, and that will actually tell us that we have a patient who is profoundly at risk, and we cannot use standalone left ventricular measures for those patients. In addition, we'll use the pulmonary arterial catheter to provide guidance for an Impella RP, which is the right ventricular assist device, not necessary for CP, which is the left ventricular assist device, absolutely necessary for an RP, the right-sided Impella. And I think one of the most important considerations is when I have patients with fulminating ARDS who are utilizing increasing ventilator support, it is quintessentially important to place a PA catheter so we actually can match our ventilation strategies with a perfusion methodology to match ventilation and perfusion. So direct measurements that we can make utilizing our PA catheter and some of the indirect measures as well will allow us to really place a beautiful microscope around right ventricular function. Obviously, CVP or right atrial pressure will allow us to look at the column of blood as it fills the right ventricle. We can also initiate with an advanced PA catheter the evaluation of right ventricular end diastolic volume and right heart ejection fraction, which expand to a whole new meaning when applied to patients who have an iatrogenic pulmonary hypertension. We can look at the PA pressures, PAS, PAD, PA mean, which are reflective of the right heart and the vascular tone of the pulmonary artery. And we can make an indirect measure utilizing the balloon on the tip of the PA catheter. When inflated, catheter moves forward and occludes everything from behind it, looking forward into the capillary, the pulmonary veins, left atria, and ultimately the left ventricle, although indirect, can be very beneficial when we're evaluating our patients. We also look at the thermal dilution cardiac output, temperature change over time. That actually also tells us about dissociation between the right heart and the left heart when compared with left heart measurement tools. And ultimately, the exchange of gas. So we're going to use SaO2 to reflect the oxygen exchange, but we're going to use end-tidal CO2 and PaCO2 to reflect the carbon dioxide exchange. So again, if we look at this beautiful cartoon that helps us to appreciate that the right ventricle is highly compliant, you can put a lot of volume with a very low pressure because that right ventricle has a muscle mass about 1/6 of the left ventricle. And to remind ourselves that that right ventricle is like the first time that you ever went to the gym after you've been laying in bed for 6 months. It's weak, it's floppy, it cannot overcome resistance. And increased pulmonary vascular resistance can occur rapidly in the face of pulmonary acidosis, hypoxia, hypercapnia, and increased airway pressure. We always expect the left ventricle to be relatively non-compliant because of the muscle mass, which is 6 times greater than that of the RV. Much smaller volumes into the left ventricle at a much higher pressure. And always really important for us to remind ourselves that we also see when we're talking about our vascular tone, that hypoxia and acidosis affect that as well. So this is quite an important point because we know that in a metabolically acidotic state, we will dilate the systemic vasculature. But in a metabolic acidotic hypoxic state, we will constrict the pulmonary vasculature. So at the very moment that you need your LV to be filled ultimately in order to eject, in order to deliver better blood flow, to get rid of that acidosis and tissue level hypoxia against a decreased vascular resistance state, at that very moment, you actually have an increased afterload to the right ventricle. So by the way, this happens every day in critical care, every day. And we want to understand it and do our very best to help to evaluate it and treat our patients most effectively. So it becomes inherently important to remind ourselves that right heart measures are relatively predictive of left heart function when everything is normal. That means in a lab, placing a catheter in a healthy patient, right heart reflects left heart, and that we can make that correlation when there is no issue. But as our patient progresses towards critical illness, we can often see right heart pathologies evolving and uncoupling the right to left heart relationship. Right heart measures, particularly in pulmonary critical care states, are not reflective of the left heart. Whenever pulmonary vascular resistance increases or when the RV function decreases. Using a right heart catheter in this state provides us information that measures and indicates what has occurred with our right ventricle, but not our left ventricle. Again, one of the most important things to appreciate and consider is that we have the opportunity to actually evaluate left heart ejection by using methodologies that measure pulsatile contour, either non-invasively or minimally invasively. And we have the ability to look at the right heart in conjunction with that, utilizing a pulmonary artery catheter. So as a major reminder, spending years at the bedside of critically ill patients, being concerned about their pulse oximeter, being concerned about SaO2 and PaO2, it is vitally important to remind ourselves, first of all, you must have an open lung, and second of all, you must have a right ventricle that can deliver blood through that pulmonary bed in order to promote oxygenation. For most of us, we use SaO2 and PaO2 to reflect the alveolus and to consider what might be happening for the left heart. But it is profoundly important to remind ourselves the right heart priority is to mobilize blood through the pulmonary vault via right ventricular ejection, via vascular tone, via mean pulmonary pressure to convert deoxygenated blood to reoxygenated blood. We must consider how important this is for us because that is a separate component than evaluating whether or not we have an appropriate filling pressure for the left ventricle. So remember, the left ventricle filled by the left atria, filled by the pulmonary veins, filled by the pulmonary capillaries, and pushed by the pulmonary mean pressure, measured by pulmonary artery diastolic pressure. So I get 2 for the price of 1 here. My PA catheter helps me evaluate the RV ejection and the LV filling. But I'll need to look at both to have a clear picture for my critically ill patient. So we remind ourselves that the right-sided pressure measures reflect the right chambers, the pulmonary blood flow, and the lung compliance. Blood flow from right heart to the left atrium requires that I have a right ventricle that allows this blood volume flow through a very low pressure system. But again, to remind ourselves that it is very easy to overload the right ventricle. It's not so easy to overload the left ventricle because the left ventricle is filled with power and mobilizes blood really effectively. The right ventricle is not nearly so powerful and can become overwhelmed by those changes in the pulmonary vasculature. So the first thing that we will see with these patients will be an increase in PA diastole and an increase in PA systole. But as the tension of that right ventricle increases in order to try to mobilize that blood, the filling volume goes down because the compliance has changed, and the filling pressure goes up. And now this patient has gained 25 kilograms under your care and has profound extravasation of volume into the interstitium. So our first goal to evaluate, is this a pure right-sided problem, or is it right-sided reflective of the backwards failure of the left ventricle? So in order to understand that, I think it's vitally important for us to consider why there's concern for right heart failure. So why is there concern for right ventricular failure? We know that if there is right ventricular failure, mortality is increased significantly. That we don't always understand or even evaluate pure right ventricular shock. That cardiogenic shock is not necessarily an LV issue, it is also an RV issue. And because we don't explore it effectively and we don't treat it effectively, RV function significantly impacts mortality and morbidity. Now that correlates beautifully to one of the most significant components of RV dysfunction in critical care today, and that's the effects of the mechanical ventilation strategy on the right ventricular dynamics. So, vitally important for us to appreciate that when we are using positive pressure ventilation, and again, not just assist control standard ventilation, although that affects it as well, but increasing PEEPs, pressure control inverse ratio ventilation, airway pressure release ventilation, strategies we're using for a patient who has fulminating ARDS. As we apply those higher recruitment pressures, that increases transpulmonary pressure. As that occurs, it puts in a significant and profound burden on the right ventricle by increasing RV afterload. As we increase RV afterload, then we have those increased airway pressures, the RV isn't filling effectively, the RA overfills, the veins overfill, and now we have reduced venous return and a high level of interstitial volume. The increasing pleural pressures that occur with positive pressure ventilation are also transmitted to the pericardium, and that limits the filling of both right and left ventricle. So I want to remind you that inducing increase in pulmonary pressure induces right ventricular dysfunction. So as we consider that and the importance of that, I want to apply this in a very basic way. If you are interested in stroke volume variation, you already understand the effects of positive pressure ventilation and the burden on the right heart, because that is what induces stroke volume variation that you're measuring as an indicator of LV filling and ejection related to ventilation. If I have stroke volume variation, I'm always going to consider that I might have right heart dysfunction as it relates to ventilation. So, the pulmonary vascular bed is profoundly affected by mechanical ventilation, and that so significantly increases the afterload for the RV, which then, of course, affects the preload for the LV. And again, this correlates so beautifully to the understanding of something simple, stroke volume variation, measured in the systemic artery or in the pulsatile quality as a variability of LV filling related to positive pressure breathing. So, pulmonary vascular resistance, intermittently changing with positive pressure breathing, reduces the preload to the left ventricle and increases the afterload for the right ventricle. Changes in pulmonary vascular resistance actually affect both ventricles, increasing the afterload to the right heart, requiring the right heart to develop a higher level of tension, and decreasing the volume load to the left ventricle, inducing a relative LV hypovolemia. Always consider these relationships with mechanical ventilation. Now, as we look at increasing pulmonary afterload and correlate that to a right ventricular function curve, what we can see, if you look to the far right, when you have a low PVR, you have a much higher cardiac output. And as the PVR increases, you're going to have a much lower cardiac output. And now I want to correlate to that to the effect of PEEP on the pulmonary vascular resistance. So we can see at 5 of PEEP, we'll have a low pulmonary vascular resistance around 250. But as we increase to 10, we have almost doubled the resistance. As we continue to increase to 15 or 20, we have significantly increased pulmonary vascular resistance. Now correlate that back down to the function curve. As we've increased the pulmonary resistance, the right-sided cardiac ejection goes down, 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 and down. And you might be looking at this graphic and say, we're never at 30 of PEEP, but it's not true, because if you're doing pressure control inverse ratio ventilation or you're doing airway pressure release ventilation, you are using mean airway pressure strategies that induce a profound increase in pulmonary vascular resistance. Our actual RV ejection fraction goes down. Now, why is that important? Because I'm talking about the actual RV ejection fraction. As PVR increases, our right ventricle is going to dilate. And so the thermal dilution quality is going to be a much shorter temperature change, which will then be perceived as an increase in cardiac output. But if I'm looking at LV output, I see that LV output by stroke volume has gone down, 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 down. So again, this is an uncoupled effect that occurs when we have an increase in pulmonary vascular resistance, limiting RV ejection, dilating the RV, and changing the temperature change over time, making it appear to be a very high cardiac output. Whoo! Our heads are exploding right now because we can apply this to a patient we took care of yesterday. So now let's look at this beautiful cartoon that shows us with an increasing airway pressure, you put an extraordinary burden on the right heart. So the right heart is attempting to eject against a much higher resistant pulmonary state. The pulmonary diastolic pressure is up, up, up. The systolic pressure is up mildly, and the pulsatile difference between PAS and PAD has narrowed. The pulmonary arterial mean pressure is up. However, we have a loss of blood flow through the pulmonary vault. Our perfusion through the pulmonary capillaries has become limited. High PVR will correlate to a low SaO2. And that SaO2 is low because I don't have an optimal blood flow dynamic through the pulmonary bed. Now, our pulmonary occlusion pressure might be elevated, depends on where the catheter migrates when you inflate the balloon. Your PA diastolic pressure is up, but now you've said, oh, this just doesn't make sense. Why does my patient look so volume overloaded when he's so profoundly arterially hypovolemic? You bring an echocardiogram to the bedside, you can't visualize the RV, but you see that the LV is relatively empty. And strategically, the decision might be to give volume, which then makes your patient even worse, because the RV does not have the capacitance to overcome the resistance in the pulmonary vault. Now, I'm going to make this graphic so valuable for you because I'm going to take the basic West model of the lung. And the West model of the lung basically says there's 3 lung zones. The first lung zone, the pressure of air is greater than the pressure of blood, so blood flow doesn't go through that area well and get oxygenated. That's known as zone 1. Zone number 2, the pressure of air is less than the pressure of the arterial blood flow. So the arterial blood flow, and that's signified by the small a here, the arterial blood flow pressure is higher than air pressure, and both of those are higher than venous. So this is where optimization occurs for gas exchange. You got to have a big zone 2 if you want to have good gas exchange. And in zone 3, the pressure of air is low and the pressure of blood is higher. So blood moves through that zone 3 without significant oxygenation. So if you're not familiar with the West model of the lung, that's why I gave this basic explanation. And what I want you to remember is our goal is always to optimize zone 2. And now I'm going to say it in a different way. Zone 1, gas is there but blood is not. That's known as dead space. And Zone 3, blood is there but gas is not. That's known as shunt. In a normal, healthy cardiopulmonary relationship, dead space and shunt are small and optimized gas exchange is large. But when I intubate you and I put you on positive pressure, I add PEEP, pressure control inverse ratio ventilation, airway pressure release ventilation, we're going to change that West model. So this next slide is Barbara's model, modified West. And in this next slide, what you're seeing is that gas cannot meet blood because what has been generated through the recruitment of our alveoli with mean airway pressure strategies, increased PEEP, prolonged die time, APRV, I have almost a full Zone 1 lung. Gas is there and blood is not. Through my alveolar recruitment strategies, in the very best, most clinically relevant attempt to open the alveoli, I have now limited blood flow through the pulmonary bed. Alveolar pressure is high, and arterial pressure, pulmonary arterial pressure, cannot overcome it. So I now have a significant dead space, which then correlates to what we call the VQ mismatch. Now you might remember I talked about ventilation and perfusion matching before. Now I have alveolar recruitment and alveolar ventilation, but very little perfusion. So despite my strategies with the ventilator, my patient is not improving and in fact is getting worse. His RV now is very dilated and his systemic edema has gotten worse. He may have profound pulmonary edema as well, and his LV is relatively empty. This strategy of alveolar recruitment maneuvers, which is optimally an excellent strategy to open the lung, must be matched with a strategy to evaluate that poor, weak, non-muscular right ventricle in order to assist with right ventricular methods to overcome the increased resistance that we've applied with our ventilator strategies. So to put that into a generic framework, when we use mechanical ventilation strategies, what's going to happen is that significant increase in RV afterload, and what that may also do is give us very misleading increases in many of our numbers, not the least of which could be our pulmonary capillary wedge. Now, part of what's happened, of course, is that the RV dysfunction is communicating through the pericardial sac and through the septum to the LV, making the LV smaller and less compliant and very poorly functional. And that decrease in LV compliance can be reflected in the wedge pressure, but the issue isn't really volume, it's compliance. And we have a diminished ventricular contractility. So in this case, this RV dysfunction has profoundly affected the LV and made the LV dysfunctional. The other important component is the significant reduction in venous return that is going to occur when we have positive pressure ventilator strategies and we have alterations in the compliance of the RV and profound venostasis. So one of those perspectives is we'll start giving volume, but we see that that volume is not transmitting through the pulmonary vault or not transmitting effectively through the pulmonary vault. And this now is going to be the time that we're going to consider the administration of inodilation. Because inodilation in this particular strategy, as I'm trying to recruit the alveoli, also allows me to support the RV in overcoming that pulmonary resistance. We can think about many things that happen and many correlations here that tell us that we have RV dysfunction, particularly in the relationship to positive pressure ventilation. Our RA pressure will go up significantly, and we're going to have a significant increase, of course, every time we get a positive pressure breath. Typically, as the RV dilates, what we'll see is we'll start regurgitation through the tricuspid valve. So now we'll get a V wave embedded onto our pressure trace of the RA or the CVP. And that V wave often will make us say, oh, this can't really be CVP pressure because it looks pulsatile. Not pulsatile, regurgitant. And our PA pressures will also go up. So these are very good ways for us to reflect what might be occurring with our right ventricle. And we're going to come back and revisit a few of these in just a few minutes. So as we look at this relationship, this vicious cycle of right ventricular dysfunction, as I've described, the RA and RV end diastolic pressures go up because of loss of compliance. The RV end diastolic volume goes up, and that dilates the chamber. And then we begin to regurgitate through the tricuspid valve, embedding that V wave on our CVP line. We now start to see hepatic, renal, and systemic congestion because of volustasis in the veins and overengorgement. And as that right ventricular chamber dilates, the septal wall will shift over into the left ventricle, reducing left ventricular filling and left ventricular function. And that means that we have a reduction in the delivery of oxygenated blood flow to all tissues. And so we start to see the evolving or the worsening of multi-organ dysfunction. And in addition to that, we're going to have a reduction in coronary perfusion. So at the very time that the myocardium needs more oxygenated blood flow, we'll have a reduction in our coronary perfusion. Now, not the least of the problems is related to how the septal wall has shifted. So in our next slide, let's take a look at why the RV becomes dysfunctional and what happens to the septal wall. Now, as we look at this visual, this lovely cartoon, you can see with a dilated RV, the septal wall becomes less mobile and it actually encroaches upon the LV chamber. So to the left, you're seeing the normal heart and the normal septum, and to the right, with right ventricular overload, afterloads increase, the preload pressures have increased, our septal wall is shifted over into the LV. The LV is compressed and it changes really from that round shape to a D shape, and that's what we see on echocardiogram, and we understand what this means. Can't fill the LV and an overwhelmed RV. So as we look at that compliance loss of one ventricle modifying the other, that we remind ourselves that the pericardium has now limited distendability and that sac is pulled tight against both the left and the right heart. And this limitation in both filling and ejection can clearly be seen when we evaluate our measures. So now, as we look at blood flow ejection patterns with RV failure in this simple cartoon, I want to focus first on the alveoli that has embedded 15 centimeters of water pressure PEEP. That actually is generating a significant resistance and pressure increase that we can see, first of all, in the wedge pressure of 20, and second of all, in the PAD pressure of 22. That backward reflection of the intrathoracic pressure change, the alveolar pressure change, and yes, indeed, the compression of the pulmonary vasculature is reflected in the RV. Remember that the RV is normally a very low pressure pump, and the normal relationship of the RV is 20 to 30 millimeters of mercury over 0. And now you see 50 over 24. And because of that loss of compliance and that resistance in the RV, that's exacerbated to the RA, which has a pressure of 26, and to the central vein, which has a pressure of 28. That high pressure gradient and the failure to mobilize blood flow forward can be seen when we look at the left ventricular side by simple issues of hypotension and acidosis. But you cannot uncover the reality without looking at the pulmonary arterial pressures and the right ventricular ejection and the right ventricular filling, which will open a door to us that gives a whole new view of what's occurred to this patient in relationship to our strategies and our methodologies to try to recruit the alveoli, which must be applauded and never stopped, but just must be matched with a ventilation perfusion relationship. So, it's important for us to appreciate that in a standard, healthy patient, not intubated, not on a ventilator, no known history of pulmonary hypertension, no pulmonary embolism, beautiful valves that all function normally. Right heart reflects left heart. But the right and left heart uncouple when we look at our critical interventions that are applied to our patients in critical care. And to remind ourselves that this uncoupling is the failure of the RV to eject effectively, which then actually promotes a failure to fill the LV. When we look at this with an echocardiogram, traditionally we can really only see the LV, and we see that the diameter of the LV is smaller and that the volume in the LV is reduced. If we could see the RV, we'll see that the volume and diameter of the RV are increased. The RV ejection fraction has gone down. The PA pressures have changed. The PA cardiac output have changed. And we have a high afterload in the pulmonary vascular resistance. Now I want to step back to the PA catheter, cardiac index, cardiac output, PA stroke volume. And I want to remind you that I am not directly measuring stroke volume in the pulmonary artery. I am measuring temperature change over time. That temperature change over time is reliant on a particular volume of the right ventricle. But the volume in the right ventricle has gone up. So the predictable quality of temperature change over time is that the temperature changing came back to normal very quickly because it's diluted in a much greater volume and will predict a higher cardiac output. But we are standing at the bedside with a patient on 4 vasopressors with a relatively empty left ventricle, and what that tells us is we have an uncoupled relationship of right to left heart. Is this always going to be true? No. But the necessity to investigate the truth is what we carry with us as critical care providers. So really, in a few summary slides, I want to remind you about the hemodynamic changes associated with RV dysfunction. A reduction in LV stroke volume, LV cardiac output measured by systemic arterial methods. That arterial-based cardiac output will have a profound variation associated with the breath. The pulsatile peripheral pressures, the pulsatile cardiac output, will have a profound variation associated with breath. And the patient will have worsening base deficit, measuring the presence of metabolic acidosis. Their lactic acid levels will be increasing, and their total serum CO2, which reflects their bicarbonate, will be decreasing aggressively. And when we look at that patient, we'll say, they have a very high CVP. And that CVP, if I have a PA catheter, if I compare the CVP to the PAD, typically with right ventricular failure, CVP will be greater than PAD. CVP will be greater than PAOP. And when I look at right ventricular and diastolic volume, I'll see that the volume is up and that the ability of the right ventricle to eject it has gone down. Now, I need specialized tools to evaluate this, to actually look at right ventricular ejection fraction, right ventricular and diastolic volume. But even if I don't have those special tools and I have a basic PA catheter or a CCO SVO2 PA catheter, I can still deduce from my basic measures that I have an uncoupled right and left heart function. So the idea behind this is we need to use a PA catheter when it's right, not to place a PA catheter in every Tom, Dick, and Harry who comes into the ICU. In the 70s, every patient had a PA catheter. Their wife had a PA catheter. Their dog had a PA catheter. Their cat had a PA catheter. PA catheters are right to use when you have a situation where you need to appreciate LV filling and you do not have significant pulmonary alterations so that you can use wedge pressure to reflect the LV. But the bigger category is in the patient who we are applying strategies that increase pulmonary afterload, and that most particular one is mechanical ventilation with alveolar recruitment maneuvers. In addition to that, if we consider a patient has a pulmonary embolus, they have a chronic pulmonary hypertension or an acute on chronic pulmonary hypertension, we'll need a PA catheter. But this is a brand new world. That's why I say, not your mother's PA catheter. The brand new world is to evaluate RV ejection, pulmonary vascular resistance, evaluate RV function in order to promote LV function, and most particularly, to match ventilation to perfusion. Because in today's critical care environment, we are frequently recruiting alveoli and attempting to induce a better ventilation without attention to the right ventricle that is weak and needs support to overcome the resistance. So we use that PA catheter when it's right, when the RV afterload is increased, and we have to understand that, when CVP is increasing, when RV tension is increasing, and when RV diameter is increasing. We're going to see that in conjunction with LV diameter decrease, LV filling volume decrease, systolic blood pressure decrease, left ventricular stroke volume decreased, and the left ventricular filling pressure rising. So one of the most important points that I can make to you is that without a PA catheter, I cannot fully understand what's occurring. When we know that wedge pressure will be higher than left ventricular and diastolic pressure, when we do positive pressure ventilatory strategies, when intrathoracic pressures are increased, when we have mitral valve disorder like stenosis or regurgitation, our wedge pressure will overpredict our left ventricular and diastolic pressure. We live with that. We've known that for years, and we live with that. But something else that's really important is to talk about CVP to wedge. When CVP is higher than wedge, we can then induce and deduce that we have right ventricular dysfunction. Now that may occur because of tricuspid valve disease, pulmonic valve disease, but most importantly, to think outside the box of cardiology and to remind ourselves that in the attempt to recruit the alveoli, we may profoundly and significantly impact right ventricular function and induce worsening right ventricular dysfunction. So in closing, I would like to remind you that LV dysfunction, of course, can induce RV dysfunction. As the LV becomes dysfunctional, the afterload can increase. That will actually displace the septum towards the right and impair right ventricular filling because we have a dysfunctional LV. But the same applies on the opposite. With RV dysfunction inducing LV dysfunction, that the volume load to the LV decreases, but the displacement of the septum to the left causes an increase in pressure. But this perspective profoundly impairs LV filling and therefore LV ejection. And to remind ourselves that increasing pulmonary pressures induces RV dysfunction. So that afterload puts a burden on the right ventricle. The right ventricle has to develop more tension. There's an increase in our pulmonary resistance. The septal wall shifts to the left. The left ventricle is relatively hypovolemic. Our arterial blood pressure is refractory. Our left-sided stroke volume is poor, and our patient is circling the drain. And one of the things we can do is to attempt to have a full view with every tool possible to look at our effect on the right heart and the left heart and to try to maximize that relationship. I'm asking you to be a marriage counselor between the right ventricle and the left ventricle. Bring them back together in the understanding of this data. So we always want to suspect RV dysfunction when arterial-based cardiac output is low despite intervention, when mean airway pressures are higher than normal, signifying the utilization of strategies that are putting a burden on the right heart, when the PAC and arterial-based cardiac output measures have a wide differential, remembering one is thermal dilution and the other is actual stroke volume, when An arterial end-tidal CO2 gradient is wide, and I'm so sorry because we really didn't talk much about that. But if arterial CO2 is high and end-tidal CO2 is low, that may indicate a failure of the right ventricle. And when you see a V wave on your central venous pressure, actually indicating tricuspid regurgitation, I want you to treat that with eyes wide open, with every tool possible, because the pulmonary arterial catheter in today's world has a new view. And it's the same view that it always was, but we're applying it differently. It's a right heart catheter, and it's best utilized to evaluate right heart dysfunction. Thank you so much for spending time with me, and I hope I'll see you soon.